Tēnā koutou katoa. Welcome. My name is Harlene Hain, and I have the privilege of being the Vice Chancellor here at the University of Otago. On behalf of the university, it is my pleasure to welcome staff and students from around New Zealand and the rest of the world who will be joining us for the next 2 weeks as we host this COVID Masterclass series of webinars. I'd like to begin by acknowledging the Global Health Institute here at Otago, who has taken primary responsibility for organizing this masterclass. In particular, I would like to acknowledge Professor Philip Hill, who is the Macaulay Professor of International Health. This masterclass was his brainchild. Professor Hill dedicated this series of presentations to our students here at Otago, who not only returned to campus as soon as they possibly could, have also decided to stay with us over the mid-semester break. In addition to organizing this masterclass, Professor Hill has provided outstanding advice and guidance to me throughout the pandemic, and I would like to publicly thank him for his support and his expertise. One hallmark of New Zealand's response to COVID-19 is that it has been evidence-based, and much of that evidence has come from experts here at the University of Otago. Experts from across the university have provided advice to government on diagnosis, containment, and contact tracing of COVID-19. Others are currently working on a vaccine. In addition, experts have provided advice and commentary on the impact of the pandemic on the disability sector, on the economy, mental health, tourism, Māori, and politics. When the country was running short on hand sanitizer or swabs, experts at Otago set up their own manufacturing organizations. Across all 4 of our academic divisions, experts have jumped in to provide assistance. Some of their assistance has featured in the media, while others have helped quietly behind the scenes. In short, when the country needed help, University of Otago staff rose to that challenge. The contribution of Otago staff has been acknowledged by the Prime Minister, the Director General of Health, the Ministries of Health and Education, and the DHBs. In my 9 years of being the Vice Chancellor here, I have never been more proud of this university. And today, I am equally proud that these experts have agreed to share more of their time and knowledge and wisdom with you through this COVID Masterclass series. Our experience over the last 6 months has underscored the valuable contribution that university research and expertise can make to the world in which we live. Going forward at Otago, we will continue to be guided by our motto, Sapere Aude, dare to be wise. We will continue to assist where we can in the fight against COVID-19, and we look forward to contributing to New Zealand's recovery. We will also continue to conduct world-class research, and the outcome of that research will continue to be shared with the public so that we can face all of the big challenges confronting our communities, our country, and the rest of the world. He waka eke noa, norera, tēnā koutou, tēnā tātou katoa.
Thank you, Harlene. I'm Jackie Herringham, the manager of the Otago Global Health Institute. I will be facilitating over the next 10 days. Just to remind everybody that our webinars are being recorded and will be available on the OGHI website afterwards. The format of the webinars is as follows. Each speaker will deliver their presentation, and you can type in questions to the Q&A, which you'll see at the bottom of your screen. After the presentation, I will read the questions aloud and the speaker will then answer. If we don't manage to get through all the questions, we'll email the speakers the questions, and written responses will be up on the OGHI website as soon as possible. Our first speaker this morning, Professor Philip Hill, as Harlene mentioned, is the Macaulay Chair in International Health at the Otago University. He's also a co-director of the Otago Global Health Institute and the Centre for International Health. Philip will be discussing understanding global COVID-19 health statistics.
Morena, everybody, and I'd like to just acknowledge all the other presenters that are going to be speaking. We've had a fantastic numbers of our staff volunteering, and also those else from overseas as well. I'd like to have three aims for this webinar. The first is to highlight four major issues to consider when viewing the global COVID-19 health statistics. The second is to briefly describe a few of the other issues that are relevant. And then I want to illustrate how understanding these issues can be applied using examples. So the first issue is that testing capacity varies over time and geographically. On the left here, we can see the number of tests conducted per day from late January to early June in New Zealand. The rise in tests done reflects to some extent the capacity to conduct tests, reaching about 1,000 per day in mid-March and rising to over 8,000 per day in mid-May. Also, as shown on the right-hand side of this slide, maximal test capacity varies greatly by country. For example, New Zealand reached capacities to do around 12,000 tests per day, and Liberia, although it has a similar size population to New Zealand, has reached capacity to reach around 1,000 per day. In terms of tests done per million up to the 18th of June across different countries, this varies greatly. Iceland, which is actually only ranked 10, has done a huge number of tests. Interestingly, the UK, with its recent focus on building capacity, has now done over 100,000 tests. New Zealand is ranked number 36, and of great interest here on this slide is that Japan has not actually done a huge number of tests per 100,000 population, per million population, and we'll return back to this issue later. The second issue is the criteria for investigation for testing varies greatly over time and geographically. So this slide shows an example of the criteria for testing and the case definitions used in New Zealand on the 2nd of March. To get a test, an individual needed to meet both the epidemiological and the clinical criteria. The epidemiological criteria were travel to Hubei or other areas with sustained outbreaks within 14 days before getting symptoms or close contact with a confirmed case. The clinical criteria required the person to have a fever plus respiratory infection plus at least one of shortness of breath, cough, or sore throat. First of all, one could argue that other countries should have been specified by early March. The statement was perhaps also too loose. Of more interest, though, was the use of this word "and" in red in the clinical criteria. This means that the sensitivity problems of each of the linked phrases are at least partially additive. So if only 50% of cases have fever, and only 50% have a shortness of breath, cough, or a sore throat, then instead of picking up 50% of cases, you actually pick up less than 50% of cases by requiring people to have both a cough and one of the other symptoms mentioned. I remember looking at the European CDC criteria around this time, and they use an "or" statement instead of "and." This means that you're likely to pick up more than 50% of cases rather than less. As I've noticed here, "and" was changed to "or" on the 14th of March in New Zealand. Also, acute respiratory infection as a statement is a little bit open to interpretation. The upshot of these criteria is that many people with COVID-19 came into New Zealand in February and March were not actually diagnosed. As you can see also on this slide, a confirmed case, where's the arrow, the mouse going? Yeah, here we go. A confirmed case is simply someone with a positive test. Over April in New Zealand, we found that we had 16 clusters of COVID-19, as described here in a table from the Ministry of Health website. Now, while 9 of these were able to be linked to somebody, sometimes not previously diagnosed, who had arrived from overseas, for 6, shown here with the red dots, an overseas origin for any of the cluster members was not identified. This suggests that COVID-19 had penetrated quite deeply in parts of New Zealand population without necessarily being widespread across the population. So let's pause to have a look at some early notification data from China. Here you can see the number of confirmed cases that are test positive by day across China from mid-January to late February. You can see that on the x-axis. The red bars are the number of confirmed cases in countries outside China. As one might expect with an epidemic with exponential growth and an increasing test capacity, the numbers were dramatically increasing until early February. Then a remarkable reduction occurred, as you can see with the arrow. This can only be due to some sort of intervention, which is highly effective. Something strange happened on the 17th of February, however, as you can see with this large bar, high bar here, which actually goes way off the top of the scale. China decided to change its case definition, as it knew that it had many more cases than were diagnosed by testing, and had identified quite a specific change on CT scan in the lungs that made them confident of reporting a whole lot more cases. However, in my understanding, it was agreed to be able to monitor the trends, case notifications had to be restricted again to test positive individuals. To illustrate this further, here's the WHO notification data from Hubei province and the 10 other provinces in China with the most cases as of March 3. The columns show the population in tens of thousands in the province, the total number of cases and deaths, and the cases and deaths in the last 24 hours. The total numbers are over here. Over to the right, I've calculated the percentage of cases who died. You can see that Hubei had case mortality percentage of 4%. Much higher than the other percentages. Indeed, at the time, the case mortality outside Hubei was less than 1% overall. This difference is most likely because only the sickest people in Hubei got a test, especially early on, and all the mild cases and those that didn't make it to hospital were simply not counted. So the declaration of the thousands of extra cases in the last slide, the high case mortality in Hubei compared with elsewhere, makes it obvious that there were a lot more cases in China that met the case definition of WHO. Anyone with a basic training in epidemiology could work this out in February. The fact that they built a huge hospital in 15 days also made the issue obvious that they had a large number of cases. The third issue, and this is the most complicated slide, is that population age structures vary greatly. This is important because young children are probably less likely to get infected and less likely to get sick, while the elderly and those with underlying health conditions are much more likely to die of COVID-19. The median age of populations across the world varies greatly. As you can see, Italy's median age is 47, New Zealand is 37, while in sub-Saharan Africa, the median age is actually only 18. So one would expect countries in sub-Saharan Africa might have relatively low numbers of death because they are much younger, while countries like Italy and Japan might be expected to have high numbers of deaths. However, some calculations around mortality are complicated. Someone might have COVID-19, which is not life-threatening to them, and actually die of something else, such as a stroke, but be recorded as a COVID-19 death. We can then think of calculating what we call excess deaths, which is the deaths that happen minus the deaths that are expected. In New Zealand, we have about 750,000 people aged over 65, of whom 27,000 die every year. If we have a COVID-19 epidemic and 20% become infected, and 10% of these people died, we'd expect about 15,000 deaths. However, the excess mortality would not be 15,000, it would be expected to be lower. However, in some countries, not all COVID-19 deaths are diagnosed or cases diagnosed, messing up these assumptions. For example, From late February to late April, Italy reported 26,700 COVID-19 deaths. But when they compared their overall deaths to the same time the previous year, there were 41,400 excess deaths. To illustrate some of these age issues, I'd like to give you some examples. I'm sorry about the fuzzy nature of this slide, which is from the Netherlands. This is Dutch data from a few months ago, split by age groups down the left. As you can see, there are very few cases. This is the number of cases here in young children. The next column is hospitalizations, shows that there are also very few hospitalizations in young children. And there were no deaths at all. This is the deaths here, right up to the age of 45. Whereas case mortality, the proportion of cases who died, reached over 10% in people over 70 and 20%, over 20% in people in their 80s. And these data are similar to data in other parts of the world. Another example is Korea, and here you can see the age groups going the other way. The youngest age group had very few cases, had no cases at all, very few cases and no deaths at all, right up to the age of 30. And this is data on incidence from France. So this takes into account the denominator population for each age group. And you can see again, these young age groups, very few cases per 100,000 people in those age groups. Indeed, Iceland did a cross-sectional study of active case finding in 3,500 people across their population, and they found 48 cases. None of the children under 10 were positive. So it's not just that children don't get symptoms or don't turn up for testing. And here are specific age-specific mortality data from China. Mortality in COVID-19 cases reached almost 10% in people in their 70s and almost 50% in people in their 80s. So you can see why countries with large populations over 70 need to be careful to avoid the virus, especially in these subpopulations, even though overall in the whole population, the case mortality might be 1% or less. And the fourth issue is the varying quality and capacity of health services globally. The reason this is important is that modern healthcare can reduce the mortality quite substantially from COVID-19, especially through ventilators. If the capacity of the health system is overwhelmed, there will be a sharp rise in mortality. In terms of ICU beds per 100,000 population, you can see that some countries are much better positioned with respect to ventilators than others. And most low and middle income countries are hugely disadvantaged in this regard. So we haven't got time to go into a lot of these ones in detail, but there are a number of other issues that may be important. I think it's becoming increasingly clear that access to healthcare is important. People might not be able to access good healthcare, but some people are avoiding going to the health facilities that they regard as unsafe. Some underlying medical conditions that increase risk of death vary by country. Population density is also important. The proportion of elderly in care facilities varies. Social practices such as hugging and kissing vary a lot. Basic hygiene, climate, and BCG vaccine may also offer some protection, but varies by different country. Also, it's becoming increasingly clear that COVID-19 epidemics are based around clusters, not so much about general spread across the population. And this has a number of implications. And death is delayed, so early mortality estimates can be misleading in the first few weeks. Now, this might be all sounding a bit complicated. So one way to consider a lot of these things together is to use what we call a cascade of care approach. So this is the cascade of care for a hypothetical country with 6,000 COVID-19 infections. So let's say that 80% of these eventually develop symptoms, but actually in this particular country, only 3,000 actually seek care. Maybe only 2,200 can actually access a healthcare facility, And then that healthcare facility only recognises a certain proportion and tests 1,500. The test is only 80% sensitive. And then there's the problem of reporting cases once you get the case positivity. This means that in this particular country, which is hypothetical, of course, only 1 in every 6 infections are notified as confirmed cases. So if we assumed, in looking at the red here, that 1% of infections across a population die, through the cascade, there's a drop-off in the proportion that end up being notified. But since those who are sick are more likely to seek healthcare and get tested, the drop-off for those who eventually die across the cascade is not as great as other cases who are not as unwell. So together, this leads to a relatively high reported case mortality, 4% versus 1%, but also some deaths are still not reported. So a third of the deaths in this case are not reported. So I'd like to close with a couple of slides, with 3 slides of examples. And we're going to look at the hardest one first, Africa. And this is the WHO situation report on one day, the 18th of June last week. So these are the top 16 African countries in terms of the numbers of cases. This is total numbers of cases confirmed. The rest of African countries have even lower numbers of cases. Of further interest is the relatively small numbers of deaths and the not ridiculously high case mortalities that are reported, which I've put here in red. Indeed, when I talk to people in several countries in sub-Saharan Africa, they confirm that their hospitals are not filling up with COVID-19 cases. My feeling is that these data reflect a relatively low testing capacity, the low median age of the population across sub-Saharan Africa, and some people are not seeking healthcare even when sick. It's also possible that the huge number of young people in sub-Saharan Africa might be blocking the virus being able to access their elderly population, which itself is small. Here in the Americas, I'd like to focus on 4 countries. The high case mortality of 5.5% in the USA, in the context of their median age, the number of care facilities, and the high ICU capacity, does reflect the likelihood that there have been and remain a huge population of undiagnosed people. Brazil also has a high case mortality and likely has a large number of undiagnosed cases. Mexico may have just as many undiagnosed cases per population and has a very worryingly high case mortality. Canada also, being slightly smaller though, has a very high case mortality, again suggesting that they have not diagnosed a large proportion of their cases. Here I show some data from Southeast Asia and the Western Pacific region according to WHO classifications from the same 18th of June report. I'd like to highlight India and Indonesia and Southeast Asia. Both countries appear to have not diagnosed a large number of cases, and their low median age may be masking this more than USA, for example. Interestingly, China has an overall case mortality now of 5.5%, which I think relates to the fact that people who die tend to die several weeks after their initial diagnosis. So the earlier slide showed an underestimate, especially for provinces outside Hubei. Singapore has a reasonably large number of cases, but an incredibly low case mortality of 0.06%. That's 0.6 of 1%. 0.06 of 1%, sorry. This is certainly due to the large proportion of their cases that have occurred in young migrant workers living in crowded accommodation. Japan is a very interesting and increasingly interesting story. They have not done a huge number of tests and have not diagnosed a lot of cases, and they have a relatively high case mortality. While they have missed a lot of cases, perhaps, they have been quite sophisticated, treating their epidemic more like a cluster epidemic than a standard epidemic. And they seem to be being quite successful. Japan's approach is going to be something that's worthy of a lot of attention in the future. New Zealand has obviously done pretty well, but almost half our deaths have come from one elderly care facility. And Fiji is the standout performer. And I believe this result is genuinely true. We look forward to the presentation from our friends in Fiji in this masterclass series. So I'd just like to close by giving you a few of the websites that I've been using and others I know have been using. And there are other websites that give a lot of information with respect to COVID-19. And obviously, these will show trends and other things which I haven't discussed. Thank you very much.
Thank you, Philip. Question time. There have been a number of suggestions that the Chinese government has actively misrepresented the case or mortality figures they've been publishing internationally. Do you have an opinion on this?
Yes, I think I covered that reasonably well from the Chinese slides I presented. Look, I think that anybody who understood data reasonably well from an epidemiological point of view could tell that they were not able to diagnose a huge number of cases early on, and that the data were clear on that. And there was a clear attempt to show that they had a lot more cases by the different case definition that they tried in February. So I don't think that China has been misleading anybody any more than anybody else is with respect to the presentation of their data.
Thank you. We have one more question. Feel free to ignore this if it's going to be covered later in the course or if it's too political. But has any research been done on deliberate underreporting or misreporting of COVID cases?
I think, again, it's really important to realize that when showing surveillance statistics, you have to have a consistent case definition. I think so the case definition has to be the evidence of a positive test. What I think I've hopefully shown here in this talk is that the criteria for testing change over time, and all sorts of other factors come into play, which lead to having to be very careful how you interpret the case, the statistics from any one country. I don't think any country has been deliberately trying to hide the number of cases that they've got.
Thank you. If there are no more questions, just remember you can put your questions through the Q&A function at the bottom of your screen. If there are no more questions for Philip, we will move on to our next speaker.